Good morning. I'm Susan Dentzer, Editor-in-Chief of the health policy journal Health Affairs, and I want to welcome you to this first in a series of debates on key global health issues and controversies. Thank you for joining us. The resolution we'll be debating today is this: resolved, that the U.S. commitment to universal HIV/AIDS treatment is unsustainable and decreases the U.S. leverage in the nation's foreign policy. Now let us begin by stating the obvious. This is a painful topic because lives are at stake, potentially millions of them. And understandably, the debate can get quite emotional. We will all agree that the Group of Eight's announcement in 2005 that member countries agreed to provide all those infected with HIV access to life-saving antiretroviral treatment was among the most noble of actions. And what that meant, whether it was fully understood at the time or not, was keeping some 30 million people worldwide on ARV treatment for 3 or 4 decades, if not beyond. That was very noble, but 5 years later, that picture of nobility looks quite different. We will all know that donor assistance in HIV/AIDS is flat to falling. In 2009, the G8 countries' disbursements for HIV were $7.6 billion. A year earlier, they had been $7.7 billion. And we also note that given the global economic situation, this trend is not likely to change anytime soon. Although the Obama administration is working very hard to meet its other global health goals, such as in maternal and child health and neglected tropical diseases, it intends to keep its commitment to increase the number of patients receiving ARV treatment under PEPFAR to 4 million by 2014. It is, however, unclear if the U.S. Congress is going to go along with that. It's also clear that even if the U.S. is somehow able and willing to deliver ever more increasing sums to global health and specifically to HIV/AIDS, it is not at all clear that much of the rest of the world will go along. Now, everybody can agree that these circumstances are unfortunate. Everybody does not agree, however, that backing away from universal access is or should be inevitable or desirable, and particularly desirable even from the standpoint of U.S. foreign policy. And this is where our debate today begins. Our debate is going to take place here under CSIS auspices in a way that recognizes that it's important to have open, civil, and reasonable debate on difficult global health issues and controversies. And happily, our debaters and discussants today are going to model civil and reasonable behavior. So let me introduce them now. First of all, to my right, your left, is Princeton Lyman, who's an adjunct senior fellow at the Council on Foreign Relations and the former U.S. ambassador to Nigeria and to South Africa. He also served as Assistant Secretary of State for International Organization Affairs, as Deputy Assistant Secretary of State for Africa, and as Executive Director of the Global Interdependence Initiative at the Aspen Institute. Todd Summers, over here on my left, your right, recently joined the One campaign from his position at the Bill and Melinda Gates Foundation. He's a board member of the Global Fund to Fight AIDS, TB, and Malaria, and the Black AIDS Institute. He's founder and former president of the consulting firm Progressive Health Partners. From 1997 to 2000, he was the deputy director of the White House Office of National AIDS Policy. And right here to my immediate left, your immediate right from me, is J. Stephen Morrison, who's director of the Global Health Policy Center and senior vice president here at CSIS. Before coming to CSIS, he served for 7 years in the Clinton administration, 4 years as committee staff in the House of Representatives, and he taught for 12 years as an adjunct professor at the Johns Hopkins School of Advanced International Studies. So let me give you a brief description of our format today. It breaks into 3 sections. We're going to have opening statements for our debaters to lay out their arguments. We'll have question and answers from me and then from you in the audience, and then we will have closing thoughts from both sides and from me. So Steve Morrison will also be offering comments on implications for U.S. foreign policy, and Ambassador Lyman will respond to those. So we're going to begin now with opening statements. We're going to hear 7 minutes from Princeton Lyman arguing the affirmative on this resolution. Todd will then ask questions of Ambassador Lyman for several minutes, and then we will switch to the other side. So, to you.
Susan, thank you very much, and thanks to CSIS for holding this discussion and for all the work it's doing on global health. And I'm glad you made the point at the beginning how sensitive an issue this is. We are talking about people's lives, and it's not easy to look at limitations on our ability to meet that commitment that was made in 2005. But I think when people made that commitment, few were looking forward to what the implications of that were. I'm not going to spend a lot of time on numbers. There's a lot of different estimates about costs, et cetera. But basically, the figures are this. There are more than 30 million people in the world today infected by HIV or with full-blown AIDS, and more than 20 million of those are in sub-Saharan Africa. And while we can assume that the other regions of the world can eventually assume the costs of treatment and care in those regions, it's very unlikely that that will be the case in sub-Saharan Africa. And if universal access is, as some people put it, 85% of those in need, we're talking eventually about 13, 14, 15, maybe 16 million people in Africa permanently under treatment for decades to come. And that's what makes this such a difficult commitment to make, and why, in its present form, it's not sustainable. Let me indicate 4 reasons why I don't think it's sustainable. For one thing, for every person now being placed under, for every 2 people placed under treatment now, there are 5 new infections in the world. And that means the pandemic is growing, and it's growing far into the future. As Bill Gates said at the recent international conference in Vienna, even with everything that is being talked about and the new innovations, we can only look forward to cutting the number of people getting new infections in half. And he says it's going to be impossible to find the money to treat all of those who need it. Now, under these circumstances, there is inevitably going to be some reconsideration, some backlash taking place among donors and even in recipient countries. Second, the politics of this is becoming unpleasant rather than pleasant. The commitment to PEPFAR did a great deal to enhance the image of the United States in Africa. But now, when you take on that kind of commitment, it can turn sour. At the International Convention meeting in Vienna, there was a lot of criticism of the United States for flatlining our commitments this year, even though, together with the private input, the United States provides 85% of programs for HIV/AIDS. And we can expect that in the recipient countries as well. In Uganda, headlines labeled the United States a murderer because we were flatlining. So what starts out to be a great and noble effort is not always politically sustainable or even positive. Now, third reason is that the rising cost of AIDS programs, and particularly the rising cost of treatment and this commitment, is going to bring us increasingly into competition with other development needs. And we see that happening already. Congress is proposing to cut the president's foreign aid requests for next year by $150 million, and yet increase the amount for PEPFAR. So the president's proposals for food security, for global warming, for education, for other new initiatives, let alone infrastructure and other things, are undoubtedly going to suffer. And we're going to see sharper and sharper debates in the development community as to where our resources ought to go. Now, the other aspect of this, which is unusual, is that by PEPFAR taking on the responsibility for half the number of people under treatment, the United States has assumed an extraordinary commitment, and that is that millions of people's lives will become directly dependent on annual congressional foreign aid appropriations. It creates an international entitlement as we have never seen before. And it's going to have as much resentment as gratitude whenever the appropriations don't meet expectations. And I can see in the future backlash on this, not only in the recipient countries, but also in the Congress, which finds its hands tied in terms of its foreign aid appropriations because millions of people are directly related to our program. I think the way we do this has to be changed. Now, there is a problem, I think, looming in the recipient countries as well as more of their resources or donor resources move in this direction. Take South Africa, 5.5 million people affected by HIV, a huge number, but it's only 11% of the population. And the vast majority there are unemployed, poor, suffering other health problems, et cetera. Sooner or later, the amount of resources going to one part of the population could create serious backlash. Now let me take a minute to talk about the foreign policy implications. An interesting thing has happened in United States foreign assistance. In the increase, the very substantial increases of the United States aid to Africa over the last decade, a more than threefold increase in aid, much of it now through PEPFAR and other through emergency food. We have gone from 40% to 80% of our aid to Africa being in humanitarian life-saving efforts. It means you can't cut that aid off. And when we face oppression in a country like Ethiopia and electoral malfeasance, or invading Eastern Congo from Rwanda, or Mugabe's actions in Zimbabwe, even though those countries get $500 million a year in aids, we have no leverage in terms of human rights, in terms of democracy, and those leaders know it. And for people interested in those other issues, looking at this structure of our aid program, I think there's also going to be some serious questions raised. Now, what this means is, as painful as it is, we have to look at this commitment realistically and candidly. It doesn't mean abandoning our commitment to the pandemic of HIV/AIDS, but it does mean we have to look very carefully at these implications and what it means for how we do our assistance, for how we balance, for what we say about what our real commitment is and what's possible, and how we continue to mobilize support for a commitment that is increasingly becoming unsustainable. And we have to look at the foreign policy implications of how we are going to conduct a range of foreign policy issues when so much of our assistance has now moved into this immutable category.
And we'll have time for further discussion
Okay.
on those implications. Todd.
Thanks and good morning. I wanted to start by thanking Susan for hosting and Steve for setting this up and Ambassador Lyman for joining. He brought his granddaughter, so I guess I'm not allowed to attack his credibility. Steve is going to really take on later on some of the discussions around the foreign policy aspects. I'm going to stick to the public health side. But I did want to kind of come back with a few quick questions. One is, if there were adequate resources, if we lived in a world where there was actually a far greater allocation towards foreign assistance related to health and development, how would your arguments change?
I think they change in two ways. First of all, adequate resources ought to be combined with adequate resources for other foreign policy and foreign aid needs. Otherwise, you continue to have this competition of HIV/AIDS driving out other foreign aid or development initiatives. But let's say you had that. Let's say Obama could double aid overall and do that. I still would suggest that this direct relationship between our program and people receiving treatment ought to be changed. And I would suggest we move toward making the treatment regime an international one, under the Global Fund or some other structure, so it isn't a direct relationship between how much we appropriate each year and exactly how many people will stay alive the next year.
Great, and that actually gets to my second question, which is, you mentioned a couple times that you think that the United States should change the approach that it has towards its support for HIV, in particular for HIV treatment. So maybe you could expand a little bit more on how you think the U.S. government should change its approach.
Well, I think we ought to start now building that capacity in the Global Fund is I think, the natural one, that we can have a single international treatment regime that provides for the drugs and the other things directly, so that people's link is to an international entity. If our money goes down one year and England's go up, the program continues. If ours goes up, fine. But I think that's one of the changes. The other is we have to look very hard at the science that's telling us what works for prevention. And there's a lot of argument about that. But I think the emphasis on cutting new infections has to be a central part of it. Otherwise, this pandemic just extends out almost forever. And the third thing, it seems to me, is to continue heavy work on a vaccine or a cure, because really without that, it's hard to see where this ends.
Great, and last question, if there isn't enough funding and if and somehow we need to ration access to AIDS treatment, who should get it and who shouldn't?
I tell you what I think is going to happen and what I fear will happen. Congress at some point is going to start looking at individual countries and say, look, this country isn't doing enough. It's either not putting in enough money, it's not doing enough to cut in new infections, so we're going to flatline treatment in country X until you get your act together. Now that's a kind of cruel way of going about it. So I think that in the terms of rationing, I do think in effect one is going to have to look for countries making major commitments and programs on bringing down new infections. Without that, I can't see politically sustaining expanding treatment in countries that don't undertake those efforts. That's going to be tough, but I think that's the rationing that will start to happen, whether we think that's right or not.
Very good. Let's move now to the reverse. We're going to have an opening statement from Todd arguing the negative to the resolution, followed by questions from Ambassador Leonard. Go ahead, Todd.
Thanks, and good morning, everybody. I wanted to start with basically the supposition that what you put out, Princeton, in terms of your article and the proposition we're debating today is a little bit more of a prognostication than a prescription. I think the sense that I have is that this is a little more about what do we do when we don't have enough resources. So I'm going to focus on ways that I think that we can look at this from a different angle, and then towards the end talk about some steps that we could take to actually make this achievable. I have 5 different statements I'd like to make. One is that I don't think that there is actually a morally defensible option. I don't know how it is that we allow 29 million people who are living with HIV and who are at some point in their lives going to need treatment to go without. Second, I think the U.S. has the resources to maintain and expand its support for HIV, in particular for treatment. I don't think it's a question of capacity. I think it's a question of priority. Third, PEPFAR has been a tremendous success. It has been probably one of the most successful foreign development assistance programs ever, and certainly one that resonates with many people in the developing world in ways that few other U.S. programs have. And we should be learning from that success and building on that success rather than tearing it down or moving off to something else. Fourth, left untreated, AIDS is not going to sit around and wait for something else to happen. It will continue to spiral forward, and we'll see again the days when health clinics and hospitals are overwhelmed with patients coming in and quite acute needs, which are substantially more time-consuming and expensive to address than providing the AIDS treatment that is currently available. Those of us who are witness to the early days of HIV, both here and in the developing world, have seen how drastic and acute those crises are and how overwhelming they are for the systems that we rely to take care of many of the other health needs that you mentioned earlier. And fifth, I'd say that we are beginning to understand the strong interconnections between treatment and prevention. That, in fact, people who are infected often don't know it. The majority of people in the world who are living with HIV don't know that they're infected. And the desire to go and get tested is linked to the ability to get treatment if, in fact, they are infected. And if we take away the opportunity to get treated, the number of people who seek to learn their status is certainly going to go down. And that, unfortunately, is going to lead to an exacerbation of the already high rates of new infections. So I think that I can go into these in some great detail, but I'm hoping that the audience will pitch in here a little bit. I do think that there is, at the bottom of this, a really fundamental question for the United States as to whether or not it's going to allow the winds of change of political interest to be the one that drives our efforts on global health. And that's a problem that we're going to have not only with HIV, but for a range of other issues that are not going to get solved in the time frame that often makes people in the political world happy. So I think some way or another we're going to have to come up with a model for addressing public health issues that isn't so subject to the kind of annual appropriation, political winds of change that HIV has become. We're not going to eradicate polio. We're not going to eradicate many of the other diseases that are out there. We're certainly not going to be able to persevere to find an HIV vaccine if, in fact, we allow ourselves to be constantly buffeted by these political winds. So I would hope that what we could come forward with is an approach to HIV that recognizes the long-term nature of the commitment, the long-term nature of the obligation of the U.S. government, and the opportunity that we have not only to address the health needs of people that would otherwise perish, but also to build health systems that are involved in providing those services on HIV.
Very good.
Thank you. And by the way, let me acknowledge my co-author on that article, Steve Whittles, who's here today. Todd, when you say it's not morally defensible to see 10, 20, 30 million people die, there's no question about that, but at the other side of it, don't you think making a commitment that really is not sustainable is morally defensible? That we build, is it right to build a set of expectations that we can't meet? Is that morally defensible?
It's a great question, and I think that your sense that we ought to be relying more on a multilateral approach rather than a bilateral approach in some ways addresses that, because the challenge that any government has is the effectiveness of reaching out on its own as opposed to in partnership with other countries. The Global Fund has really provided the United States with a great opportunity to support HIV and TB and malaria programs in over 120 countries, far greater reach than the priority countries reached by PEPFAR. And it also offers an opportunity for us to build on our money. We get $2 for every dollar that the United States government puts in. And lastly, I'd say one of the benefits that we have is that a lot of that money goes directly to the country for programs that they design, rather than going to programs that are more hatched in donor capitals and more often supported through international organizations. So I think that one of the avenues here for the United States government is to follow this multilateral approach, and I think that actually allows for a little bit of the balancing of support that you talked about, in some ways kind of attenuating against the political change that many capitals face year to year.
Let me ask you more about this question of treatment and prevention. I know there's a lot of studies and arguments about it, and it's a strong argument for continuing a heavy emphasis on treatment. But in the reality of PEPFAR itself, the Global Health Initiative, and a lot of other studies, look, how would you see the balance really in the future between increasing the level of people brought under treatment and attacking the whole range of things which impact on prevention? Treatment is one of them, but there's gender issues, there's access, there's discrimination, there's all kinds of issues there.
I think your article certainly called out for a greater emphasis on prevention, and certainly absolutely support that. I think the commitment to treatment is not sustainable if we don't slow substantially the rate of new infections. So there absolutely has to be a greater emphasis on prevention. That includes actually a lot better use of the tools and technologies that we have already at our disposal. I think that during the Vienna conference, Bill Gates and Bill Clinton both called out the need for us to do a much better job than we currently are of adapting strategies to the particular epidemics faced by countries, which is a way of saying that if you have an injection drug user driven epidemic, you don't do general community mobilization, you do syringe exchange and drug treatment. And we are so far doing poorly at that. Second, I think that the U.S. government and Steve's Smart Power Global Health Commission has really highlighted this. The U.S. government could do a lot more than just write a check. The U.S. government has tremendous influence in many of these countries and could be using that influence to help change some of the policies that help to make HIV worse. Certainly, the inferior legal position of women is one, the lack of access to education, particularly for girls and young women, simple economic development opportunities. All those are part and parcel of HIV prevention. And we've done a pretty poor job up to now of sort of making the full armamentarium of tools available to the U.S. government all align against HIV rather than just writing a check and sending in a few technical assistance folks.
Very good. We're now going to have some comments on the foreign policy dimensions of all of this from Steve Morrison, and he'll speak for the next 5 minutes.
Thank you. Thank you very much, and good morning. One just quick remark about the nature of this debate. I think Princeton and Stephen have done a big service in trying to introduce a careful and reasonable discussion around these terribly difficult issues with a level of sensitivity and realism in a moment in which we really are in a major transition. We have moved out of the high growth phase of the last decade, and we are now in a period of great uncertainty and slowed growth. AIDS exceptionalism and the AIDS threat have changed, have shifted, have diminished as a factor. There are other factors coming into this, most notably the global economic recession. And the U.S. finds itself in a very conspicuous position because we have, in fact, been more robust in preserving our leadership as against other G8 member states and African governments themselves, who have, both among the G8 states and African governments, have slackened significantly in their commitments, which has put an ever higher burden and expectation upon U.S. policy. And in this phase, I think we do need a new lens and a new form of assessment and way forward that is constructive and honest and forward-looking. And I think Princeton, you and Stephen have helped us a great deal in doing this. I've been asked to speak on the foreign policy implications. The core thesis is that the PEPFAR commitments have limited and weakened our influence on other important issues, and I take it to mean democracy, human rights, governance issues in key states where we've made the biggest concentrated commitment. And you cite in your argument most notably Ethiopia and Uganda with some reference to Zimbabwe. You could include Rwanda, and I'll say something about South Africa in a moment. You're suggesting that when you go from a 40 to an 80% concentration or even higher concentration of humanitarian relief plus health investments, that leaves you overwhelmingly committed over the long haul with very limited leverage in those countries, and that is highly problematic. A couple of points around that. First is, when you look at Rwanda and you look at Uganda, this is a problem that has been with us well before PEPFAR. Our ability to get leverage over these governments has been compromised by several factors going back at least 15 years. One is the identification with their leaders at the end of their internal conflicts when the EPRDF came to power, when Museveni came to power, as new leaders. And the embrace that we made, which was a mistake of foreign policy, put us into an embrace that it was very hard to walk back from. Then we hit a decade of grave security concerns, 9/11, et cetera. And I'll remind everyone that it was 12 years ago tomorrow that the Dar es Salaam and Nairobi bombings happened. And those were well before 9/11, obviously. That was in August of '98. Those were profound events, and they profoundly drove our bilateral relationships. And those security dimensions remain very fundamental. I just remind you of the Kampala bombings of just a few weeks ago, of al-Qaeda extending its reach, our concern about Sudan, our concern about Somalia, our concern about al-Qaeda within the region. That is the central factor that limits our ability to influence these governments on the governance side. I think what PEPFAR has done is added a new dimension that makes it even more conspicuous how difficult it is in the Horn of Africa for us to have a relationship in which we can use our engagement to bring about governance changes. South Africa, I believe, is a good counterexample because there we've seen in the last year, a dramatic turnaround of approach on health and the commitments on health. And we should perhaps talk a bit about the degree to which that shift was reflective of an accumulation of American and other pressures and criticisms, along with internal criticisms, around the positions taken. I think you could make the case that the $620 million a year of assistance that we provide on health in South Africa did give us some leverage with them in arguing that they really need to depart from the Mbeki-era policies, which were so difficult and so problematic. We could talk a bit more about the fact that the investments in PEPFAR bring significant benefits in terms of popular opinion of the United States in these countries. They are a very powerful soft power tool, and we've seen that reflected in the Pew studies, in the Kaiser studies, and elsewhere. They've also proven to be a very powerful tool at convincing American opinion of the value of staying with these commitments. And that factor has changed the outlook domestically around foreign aid. And I think I'm digressing a little bit from the argument that you're making there. So we come back to the question on foreign policy, ultimately the so what question, which is how, if we admit to ourselves this problematic situation we find ourselves in, does that change our strategies? Or do we just have to keep lumbering along and be smarter in the way that we engage with these governments? I agree that PEPFAR does not add additional leverage on governance issues, but I don't think we should be surprised that that is the case. I think we should be looking at the Ethiopians and Rwandans, aware that this is a long-term problem that we grapple with and we will continue to grapple with in a highly insecure region. Thank you.
Great. Well, it is now my turn to do some inquisition of these three fine folks. Let me start with a question on an area that I think I sensed some agreement between you on, and that is the notion that we ought to shift our support from the bilateral structure to a more multilateral framework, potentially giving most of our assistance for HIV/AIDS through the Global Fund. One of the reasons why we didn't do that in the first place was, of course, we were horribly distrustful of multilateral institutions, right, and in particular the new Global Fund. And there was a great concern that without tight U.S. control over potential distribution issues that would arise by corruption, et cetera, that we would not be able to make the case adequately to American taxpayers that this was a sound program. What's different about now that suggests that we should push this all through a multilateral structure?
What I think is changed now is the realization that if the U.S. tries to carry this obligation of its own, to carry half of it directly, as I've suggested, it's not going to happen. It's going to be unsustainable, and there's going to be backlash against the United States. But it's going to take years to do this. The Global Fund isn't capable of doing it now. You also run the risk of losing that direct support of the American people that Steve mentioned. So it's not an easy proposition to do. But I think that if we start now building that capacity, building the structures of accountability, in 3-4 years, we should be able to have a single entity like the Global Fund managing much of the treatment, at least the logistics and output, So it isn't directly from us to those people. But I think it's going to take some time. But I think we're not going to be able to carry this responsibility directly ourselves, and we have to start building that capacity now.
Todd?
Two things. One, I think that in some ways it's not accurate to describe the Global Fund and the U.S. PEPFAR program as somehow completely distinct. In fact, the Global Fund contribution technically comes through the allocation given to PEPFAR. And in many places, the U.S. government has been working very closely to help countries manage the resources made available through the Global Fund. The second, Global Fund is really just a financing instrument. It's a check-writing, fundraising effort based in Geneva with no staff outside of Geneva, whereas PEPFAR is not only U.S. resources in terms of money, but it's U.S. resources in terms of incredible technical capacity at USAID and HHS and elsewhere. I think that the shifting of balance could really be a way to graduate countries that have been able to develop and begin implementation of sound HIV strategies that combine prevention and treatment in an effective way, and then to move them off so that primary resources are coming to the Global Fund, and the U.S. technical support and bilateral resources come down some level to more of a maintenance effort. And that could mean then the U.S. could turn its efforts and its technical assistance support to other countries that may be more in need. The last thing I'd say is that I think that there's the benefit of providing support through an institution like the Global Fund is the matching resources, it's the ability to be in partnership with other donor countries. But the most important to me is that the strategies that are developed there are country strategies. The Global Fund provides obviously a good, strong technical review of those to make sure that they follow good science. But the reality is that those are strategies developed and implemented by the countries themselves. And for sustainability, having the countries do for themselves is a much more sustainable pattern than having the U.S. government do for those countries.
Steve?
I think it's going to be very difficult to imagine this administration working with this Congress in this next phase to push an expanded multilateral approach through the Global Fund or through the World Bank or through other institutions, if only because the debt and deficit pressures and the scrutiny over those foreign aid budgets, there's going to be a tendency, I think there will be a natural tendency towards ever greater, and I think we see the evidence of it, ever greater emphasis on a kind of bilateral approach. So the question is, what might the motivation and argument be that could pull that forward? And one argument might be that we've seen the G8 weaken. The G8 was the G8 donor countries were the driver of the last decade.
Mm-hmm.
And that's done.
Mm-hmm.
And it's going to remain in that status for the next period of the Euro crisis working itself through. You cannot rely on the G8 to be the driver when the UK and the US are the only, and the Canadians to some degree, the only standing robust, and the UK are heading towards a 25% reduction in their overall budget. So perhaps there's an argument that U.S. leadership could be used as a way of trying to operate in a G20 world, in a way to get other wealthy parties behind an approach that brings benefits to the poorest developing countries, as well as to other places that have large poor populations that need assistance. And perhaps this is a way that you could leverage a renewed set of commitments in the midst of an austerity era. But I think that's still going to be a very difficult diplomatic task, but it's one that will require essential U.S. leadership on that. But we haven't seen that turn yet.
No.
But I do take your point that if there's an unsustainability and you don't want to walk away from the commitment, you have to be looking at the multilateral track as an alternative track. It doesn't abandon the bilateral,
Right.
but you could enhance it as a way of trying to deal with the new realities that are in front of us.
Can I jump in on this one sec? Because I think that during the election cycle, candidate Obama was very strong about the importance of multilateralism. I think President Obama has been less engaged in multilateral efforts, and it falls back in some ways to the old adage that you get more leverage and control when you manage your money bilaterally. I think that this connects to a very important discussion and debate that's happening around the GHI, as well as the President's Security Directive and the Quadrennial Development Review, around the degree to which our development assistance should be connected to our foreign policy interests. And in fact, one of the things you highlight, the sort of the reverse of what you highlight, is that when you're providing humanitarian aid, it's hard to use people as pawns in your foreign policy efforts. And I think in this case, hopefully you're right, that we don't have a good ability. One of the challenges of multilateralism is that actually you have to focus on the development needs rather than other aspects of our foreign policy interests. I think that what we could certainly do is to balance this desire to fund and support multilateral efforts with a continued commitment to bilateral engagement, that the two are not necessarily in tension, and in fact could be working synergistically. The Global Fund has to succeed in countries, and the Global Fund success is still going to be largely dependent on partners in those countries helping countries develop and implement good strategies. So there isn't this kind of, if we give the money over to Geneva and it goes to the countries, we've lost all our control. I think that the U.S. still has and must maintain a strong connection to what happens in country. The last thing I'd say is that I think you make an argument that we've lost some of our connection and our influence with the governments of these countries. That may be so. I'll let you foreign policy experts debate that. But I think that it's certainly true that people in those countries have probably a far greater respect for the United States because of what PEPFAR has done for them, in many cases saving their lives. And I think that the awareness of PEPFAR on the ground with people who are living in Africa and in Asia who have benefited is far greater. Whether or not that's translated to the governments feeling that same kind of connection remains to be seen.
Let me ask a question that puts this into the larger global health context. It is very much the case that there are many, many more deaths around the world from non-communicable diseases, chronic disease, particularly cancer, than even HIV/AIDS. One of you made the point that the era of AIDS exceptionalism is over. Is it really? And if one assumes that more and more attention will be focused on non-communicable disease burden, the UN will have a major conference on this next year. Why is it not the case that the U.S. will increasingly be urged to make greater contributions there? Why should AIDS remain unique when there is so much greater global disease burden coming from other conditions? Ambassador
Well,
Long.
you already hear this, and I think the President's Global Health Initiative tries to start to address this by taking a broader approach to health systems. But I think it's an argument we're going to hear a lot. Now, there are several things unique about the AIDS pandemic that has made it so prominent. One is that we have treatment medicine, and you can see the life and death difference right up front, whereas when you're talking about cancer, you're talking about environment, nutrition, and a whole range of other things which are harder to put your fingers on. And second, because it hits people in the prime of their life, and therefore it has an effect that's different in a lot of ways. So several things have made AIDS a highly salient part of it. But I think that health is just one area where other needs are going to come into play, other diseases and other health, but also food security. I mean, this is a big issue of hunger, and the President's new Feed the Future initiative. We just see in the paper today, wheat prices are going to soar, hunger is going to increase. And then we talk about climate change. So I think we have a real problem here in that sustaining an AIDS program which takes up billions and billions of dollars, and we don't address some of the others, is going to be hard. Now, dealing with Congress in this regard is Congress likes bilateral programs, but I think Congress itself has to see in the future that carrying this kind of responsibility, seeing headlines in Uganda that the United States is a murderer because we flatline, this isn't what Congress wants to see. And that, it seems to me, is going to be the incentive, I hope, for Congress to say, well, maybe we ought to need to strengthen this multilateral framework so it isn't all falling on us, and then be able to deal with some of these other issues. Let me comment a little on the foreign policy, if I can, because I think what we need to do in this regard is not to walk away so much from humanitarian aid, is for our diplomacy to recognize, and for Congress and human rights activists to recognize, that there isn't a connect. It isn't diplomacy and development are twin pillars in a narrow sense. And if we want to have influence on human rights and democracy, we have to mobilize other means of doing that. And I won't go into that in time, but it's going to take education. When Congress sees terrible human rights depredations and says, but how come we're giving this country $500 million a year? One has to say, well, we have to have a different approach to that. And I don't think that is widely appreciated. You often see in the press, such and such a government has done something terrible, and yet we're giving them $500 million a year, not realizing that we've tied ourselves in on that $500 million.
Todd.
I actually think that there's some great stories there where the U.S. government has been able to look beyond difficult governments to the needs of the people in those countries and find mechanisms to address the needs of the people without necessarily supporting the governments that are so troublesome. I think global fund support goes to a number of countries that are otherwise ineligible for U.S. foreign assistance. I know Food Aid has done some of the same things. So I think there are good stories to tell about understanding that the people in those countries are not the problem. It's the governments of those countries that really need to get some attention. The other thing I'd say is that this competition that you talked about, Susan, between non-communicable diseases and infectious diseases, and particularly HIV, is certainly real. But the dichotomies or the tensions that are often drawn between these things seem to me to be largely specious. There's been a lot of discussion around whether or not we should support AIDS, or we should put the money into maternal and child health programs, or we should put the money into health system strengthening as opposed to AIDS programs. And to me, those are arguments that make sense in capitals. They don't make no sense in the real world. The reality is that AIDS is a leading cause of death for women of childbearing age. If a kid dies of malaria, a kid dies of TB, a kid dies of AIDS, or a kid dies of diarrhea, I don't think it really makes that much difference to the parents of that child. So I think that we have to, in some ways, stop playing one disease off the other and recognize that the only way we're going to be able to meet the comprehensive needs of people, both for infectious and non-infectious diseases, is to just increase the amount of support that we provide and do a better job of using that effectively.
All right, we are now going to move to questions from those of you in the audience. We're going to take 2 or 3 questions at a time, so I'm going to basically combine a couple of questions into one in the interest of time. I would ask you to ask one brief question. Be provocative, be brief, be seated. Please identify yourself by name and affiliation. Please indicate if the question is directed to a particular person or persons on the panel. And we have 2 microphones available in the audience to amplify your voice as you ask questions. So let's start back in the rear. Let's take this one, and this one here for the first 3.
Thank you. Good morning. My name is Tom Myers. I'm from AIDS Healthcare Foundation. The question is to everybody, I guess. My question is, what's the proof or the evidence that these programs are in fact unsustainable? It seems to be taken as an article of faith. The WHO estimates currently there are about 14 million people worldwide with HIV and AIDS who need treatment right now, as opposed to the 30 million people who have it. There's a difference. In much of the sub-Saharan countries, cost of these drugs for a year is under $100. Drugs for everybody who need it now, under $1.5 billion. The US commitment currently is about $7 billion. Why is it not possible to provide care for all who need it for that amount of money?
Okay, thank you.
Thank
Let's
you.
question in the front here.
Yeah, David Bryden with Infectious Disease Society of America. Just a comment and a question for Todd. The comment being about the political argument that's being made. I think it's an interesting argument, but I think it needs some evidence. I think and without that evidence, it sounds like sheer speculation. We need some polling data. We would need some questions posed to political leaders in Africa, and I think it's a mistake to draw conclusions from a headline in Uganda or from the opposition or criticism that we heard in Vienna of the Obama approach to funding to somehow come to the conclusion that we can expect a major backlash in the future. That doesn't logically follow. You need more evidence for this, for projecting that. And the question is actually for Todd, when it comes to some of the economic descriptions that Steve was saying, how is it that the One Campaign or the U.S. Global Leadership Campaign somehow didn't get the memo? I'm glad you didn't get the memo, but somehow didn't get this message, and yet you persevere in trying to double foreign assistance, in trying to go further. Are there some political, coming back to politics, is there some political data or some political sense you have? I mean, we do have 100 members in the U.S. Congress have signed a letter around the Global Fund asking the U.S. to double its contribution. Perhaps that's evidence, but why is it? How is it the One Campaign and USGLC still have that confidence to push forward?
Okay, great. And then we had a question here in the front.
This question is for Mr. Lyman. My name is Darren Churikian. I was reading your article, and I wondered how, looking back over the history, when PEPFAR jump-started sharp increase in AIDS-related assistance worldwide, how did the G8 in 2005 come to its conclusion that it is possible to treat all people infected with HIV antiretroviral treatments?
Okay, let's start with that first question. What is the proof that the U.S. commitment to universal coverage is, in fact, unsustainable?
Well, I think the evidence is out there. I mean, people argue about how much it costs for treatment, et cetera, but you take the UNAIDS estimate of what we should be doing this year, and it's about twice as much as the world has sustained. And if you look at the projection of increased numbers coming onto treatment, and you look at the estimates that people have made, you're talking at least of $25 billion a year in these costs, and that money isn't there. It's just not there. And to assume that it somehow will be there is, I think, unrealistic. And even someone like Bill Gates saying it's unsustainable. It's unsustainable at this point because the cost isn't just the cost of medicine. It's all the logistics that go into it, all the other aspects of the program that go into the totality of the HIV/AIDS program, and we can see what the projection of costs are against the money that's now available.
To jump to that third question quickly, why did the G8 make this commitment in the
I
first place?
think it made the commitment as the reality of the degree of the pandemic, the moral argument, the overwhelming moral argument pressed by people deeply concerned with this issue, that you had medicine here saving people's lives and poor people couldn't access it. It was just morally indefensible. And so it was a time when people were projecting doubling aid levels, et cetera. And I don't think anybody sat down and did the calculation of what this meant. I frankly had been arguing for years that people needed to do that. But if you did that then, they may not have made the commitment. So they made the commitment. It was the right thing. It had a lot of political gains to doing so, but I don't think they ever sat down to say, what is this really going to mean 10 years from now?
May I add to that?
Please, Steve.
When you look back at 2005, the economies were robust. Budgets were pretty good. You had a nucleus of global leaders in the G8 who were willing to push this. You had the Bush, Blair, Chirac. You know, you had a combination. Neither of those is present today, and so there was this momentous push and this moment of high expectation and commitment, and those, you know, I think it was a pretty sour moment in Muskoka in June, when those commitments were quietly retired in an official way, marking that sort of shift to this new era.
So I think what we had in the Glen Eagles was leadership, and what we've seen so far is a lack of leadership. I think the evidence around the sustainability really is a little bit more around, are we going to get the resources we need, or are we going to acquiesce to what we're getting so far? And I think that's the tension. We just have to do a better job of making the case. When I started doing AIDS work, it was a long, long time ago, and I came to Washington, D.C. to argue for the Ryan White Care Act. Congress had just passed this act as an emergency relief act for the United States to provide domestic support. And unlike any other emergency relief act, it actually appropriated no money. So the Ryan White Care Act started with $0. So I went around to my members of Congress and I said, we'd really like some money. And they said, well, that's a very difficult year, very tough year. We're under a lot of budget pressure here. And I'm like, wow, I didn't know. No one told me in Boston that we're out of money here. And then I go around this meeting room and all these people filing in the halls and cameras and everything. What's going on here? And they said, oh, this is a hearing on the savings and loan bailout. And I'm like, oh, what's going on? So, well, they just gave another $70 billion to the savings and loan bailout. I'm like, well, they just told me we were out of money. Fast forward a couple decades, I was sitting there thinking about this question. I was listening to PRI, and there's a guy there who's the chief logistician for the Army for General Petraeus. And he says, we spend $20 billion a year air conditioning the tents for our troops. And that if we just put some spray foam insulation on those, we could save a couple $1 billion. And he doesn't know why they haven't gone ahead and done that. So I just would argue here that we're going to thrash ourselves to death trying to figure out how to prioritize heart disease or car accidents or HIV or maternal and child health. We could have that argument all day long, but what we really need to do is go to the bank and get some more money, because the money is there, it's just being spent on other things.
Which I guess is the answer to the question of why you persevere in the effort to grow.
I didn't get the memo because I've only been at one for 5 days. So,
Okay.
Do you want me to deal with the political evidence? It was the question on
Sure.
the evidence. Look, there's a number of things about the political fallout of this. What we're seeing is the beginning of something I just think we're going to see more of, in which the role of the United States, when you make a promise and then you find you can't commit it, there's a backlash. We're beginning to see it. I think we're going to see it in other ways. But I think the bigger foreign policy aspect of it is the one that Steve discussed, which we can already see. During the run-up to the Ethiopian election, there was a lot of talk about why don't we do more to stop what's happening in Ethiopia. And Johnny Carson, the Assistant Secretary, said, I can't cut off humanitarian aid to Ethiopia, and I won't do it. Well, it was an admission that, look, we might have $500 million of aid going to Ethiopia, but when it comes to votes, and when it comes to human rights, and when it comes to democratization, I can't use that leverage. That's a reality. I'll give you another example. We cut off aid to the Ivory Coast, Cote d'Ivoire, some years ago because of the political situation. That's a powerful thing. We're cutting off aid because there's a coup or something like that. And when we did that, aid went down to $2 million a year. Well, year by year by year, with PEPFAR and everything else, we're now giving $120 million a year to Cote d'Ivoire, where we've cut off aid. Well, it no longer says something to say we're cutting off aid if it means, well, that doesn't include the $100, $200, $300 million. Now, that means you've got to change the way you approach other issues. And I think just facing that reality, that your aid program is not, if it's going to be structured, give you that kind of leverage and ability on a whole range of issues, is an important thing for the Secretary of State, for Congress and others, in terms of what we think we're getting for tripling aid to Africa on a whole range of issues. That seems to me is a reality, and it's already evident.
Let's take our next group of questions, and we'll take these three. We'll start here, and then we'll come over and pick up that last one. So, yes, please go ahead.
Thanks for having the event. I'm Matt Cavanaugh from Health Gap. To Mr. Lyman, it seems like the conversation on sustainability is only if we understand our political interest to be so narrow as the immediate responses we can get from particular dollars. I'm pretty shocked, actually, by the disconnect between the argument that, as you've said, you've been making for quite some time, this is not a new argument, and the science and the new exciting pieces coming out of Vienna. That, in fact, two really key things that I'd love for you to address. One is the reality that treatment as prevention is not just as the important piece that Todd was saying about testing, it's also that we're seeing 50% reductions when ARVs are scale up in new infection rates, 93% reductions among discordant couples. Huge science that we should be taking advantage of. And second, that there are models out there that are actually asking the question, how do we win? How do we use the technology we've got with treatment as prevention, but also with circumcision and condoms and combination prevention to actually create a model where we win? Isn't it actually the definition of political cowardice to instead, and diplomatic cowardice, to be so worried about being criticized that you refuse to take the step out and take responsibility for what might win? And instead, isn't it hugely positive for the United States to be out front crafting a strategy to win, investing the resources to do so?
Okay,
and
thank
just
you.
one quick other question, which is simply that, isn't it true that in fact in Uganda and Ethiopia and everywhere else, military aid has not even close to been talked about being cut off? And so if we really want to talk about strategies to actually influence, the fact is Museveni doesn't care about the AIDS programs, he cares about the guns.
Okay, let me once again remind you and ask that you please keep your questions short and succinct with as few parts to them as possible. Next question, please.
For me? Oh,
Yes,
okay.
Chris.
Hi, my name's Chris Collins. I'm with AMFAR. Thank you for the presentations. Maybe there's some overlap with the question that we just heard. My question was going to be, why are we framing the conversation around the ways in which PEPFAR is a liability, rather than having the conversation about how PEPFAR is a huge opportunity going forward? And I'll give a couple examples. First of all, as Todd said, PEPFAR has been enormously successful on a diplomatic as well as humanitarian level. And it's an incredible foundation for what the President wants to do on the Global Health Initiative. In fact, I would argue that you can't accomplish GHI goals if you're going to flatline the foundational program of that response. Maternal and child health, a key focus for GHI. HIV is the leading cause of death among women and the knock-on effects in terms of child health and treatment. But also the science is now allowing us to change the conversation. We're going to have a microbicide in several years. We've established that ARV prevention can work. Treatment costs are coming down, and there's a new movement to make treatment more efficient. And finally, leverage. The investments in PEPFAR give us many opportunities to increase our diplomatic leverage, our partnership agreements, which we negotiate with countries. I would argue that what just happened in Uganda around the MSM law and the death sentence that was going to be imposed on MSM, that we were able to, our State Department was able to engage very effectively in order to turn that around there. So I've seen a lot of diplomatic opportunities in PEPFAR, and I think one of the questions we ought to be asking again is not how does it limit us diplomatically, but how do we have more opportunities we're not taking diplomatically because we are negotiating partnership agreements every few years with every country.
Okay, I see I'm being completely ineffective in asking you to keep your questions shorter so that we could get more of them in. So let's make another noble effort in that
Good morning.
regard.
Thank you for the excellent discussion. I'm Kathleen Kurz from Academy for Educational Development. I work more from the development side than the diplomatic side, and what I'm not hearing much of at all is what are we doing within either the PEPFAR program or the DNG to increase, if you will, the HIV governance from the countries? What are the countries doing? What kind of what are we promoting so that the countries can do more within their, albeit limited, budgets to particularly on the prevention side, so we can get down to that Bill Gates, sort of maybe we'll only have half as many new infections.
Okay, let me try to synthesize these questions a bit. One theme is, why are we talking not about how we win this effort against HIV/AIDS, given the progress that we've seen in the science, given that there's a microbicide on the horizon, given what we've seen in circumcision, male circumcision, et cetera? And isn't it diplomatic cowardice on our part not to be seizing those opportunities? Let's start with that one.
Yeah, I certainly don't want to suggest and wouldn't advocate that we're turning away from the battle on HIV/AIDS nor from PEPFAR. But I think to define that battle is universal in terms of universal access is what I think is unsustainable and will eventually undermine some of the support because we won't get there. Now, there are new treatments and new opportunities that are coming up, and they will take years to implement. And meanwhile, the infection rate continues. And as people like Gates said, yes, that will cut the infection rate in half. But that's still over 1 million new infections every year. We've got a long-term problem here. And if we only define it in terms of universal access, we're going to lose support over time as that goal does become unsustainable. And we need to redefine the objectives. No question that PEPFAR has been a great success and something we can be proud of, but it will be a mistake not to face up to some of its limitations now and begin to reshape it. In terms of its political value and its ability to give us leverage on issues related to HIV, certainly it does, and we get a lot of benefits from it. But it does mean that there are other uses of foreign aid that we have now given up for that purpose. That's okay, as long as the rest of the foreign policy community understands that and says we've got to find other instruments to value. By the way, military aid, yes, important, but a very minor part of our aid to Africa, about 7%. So it doesn't give you that much leverage.
Todd, same question to you. Is it not the time to be seizing all these opportunities rather than suggesting that we can't rise to meet them?
Yes.
Okay, that's easy. That was a tough one for you.
Can I jump on the second question, which we didn't, or the third question, which we didn't hit about, which is this question around supporting better governance in country. And I actually think that Ambassador Gooseby deserves a lot of credit for his recent commitments to have in the U.S. play a much more proactive role with countries in helping them to develop good, sound, effective strategies. And in fact, in more ways than has been the case in the past, making U.S. support contingent upon developing good, sound strategies. He's also talked quite a bit around the importance of sustainability through building local capacity and investing more of the resources to helping countries do for themselves rather than having what was more the approach in the early years, which is providing an emergency response that was often around or on the side of country programs. So I think that his willingness to step out and say we're going to put more money into programs only if they work well and the countries have got good strategies, and to put more money into country capacity certainly is a long-term solution. The last thing I'd say is the Global Fund in particular has made quite a strong commitment to local governance, and beyond that, beyond just governance by the governments, to in fact require that proposals submitted to the Global Fund come through coordinating groups that are multi-sectoral, so that you're bringing in the private sector, faith-based groups, civil society as part of the solution, rather than just having this be a government-to-government response, which is more the case with PEPFAR.
Steve.
In response to Matt and Chris's intervention, I think we all agree it's fundamental that there needs to be forward momentum and seizing upon the positive gains and the lessons that we've seen as the way of sustaining the commitment and the engagement. And I also agree that prevention has to be taken up in a much more strategic way as part of that strategy in convincing people that the arc of the epidemic can be altered. Getting back to some of the points Princeton was making about the unsustainability and the mathematics around treatment versus new infections. And if we show that that is a strategic goal and that we believe that these innovations and these gains move us closer to that, that becomes the kind of vision that can win, I think, to use that
And that
term.
was the argument that Bill was trying to make in Vienna, which is that there is a way to show an end game on HIV. It is a long-term strategy. where we begin to build on tools available now with tools available tomorrow and tools available farther into the future. And that together those things begin to show a drop where we start to see the rate of new infections dropping below the number of people that are added onto treatment.
The difficult part is how do those goals match up against available dollars? Because we are now in a world in which the African finance ministers have gone on record as walking back from the Abuja commitment and said point blank they're not going to hit that 15% target, and the scarce dollars that they acquire are going to go to other objectives. And we are also in a world, not a post G8, but we're in certainly a post Glenn Eagles era, in which the majority of the G8 finance ministers are saying we're not going to be there in this next period, anywhere near what was projected before. And you can say, okay, let's turn multilateral, let's make sure the U.S. position remains robust. That's still, those are all sensible ways. Let's put prevention front and forward, but it still leaves you with a big gap on the material requirements to get there, and it leaves a big uncertainty as to what is the goal. What are the new goals? In 2005, we had universal access. We had commitments of 15% budgetary. We had projections on donor resources. Those are not there now. It's not clear to me what are the realistic projections of the resources and the goals that you're going to. And that, I think, is why there's so much angst and uncertainty right now.
That's exactly right.
All right, we're going to move now to closing statements. First, by the affirmative side, Princeton Lyman, and then negative side, Todd Summers.
Well, thanks, because I think Steve put it very well. It's not to walk away from a commitment that is, for all the reasons we've talked about, extraordinarily important and morally important. But we have to redefine the goals in ways that will sustain the commitment. What worries me most about this is that these various pressures that we've talked about will lead to a walking away from the commitment on HIV/AIDS unless we redefine the goals in ways that show people that it is sustainable, that there is an arc, that there is a way. Yes, it will last a long time, but we aren't chasing an ever more distant goal of universal access, which we don't seem to be able to get at. And I think there are a lot of ways to do that, but it takes coming up with a realistic set and facing the reality, unfortunate as it is, that we're going to face some hard budget times, particularly in the next few years. On the foreign policy front, I really do think it's important for people in Congress and the State Department and elsewhere to think a lot about what it means when our foreign aid is so heavily structured in this direction, when we're working with trade ministers on AGOA and our trade capacity programs may be zeroed out this year. When we talk about climate change, and when we talk about democratization and other issues, and looking at that and saying, what other instruments do we need to bring to bear? And I won't go into them in detail, but civil society, again, multilateral efforts, trade, et cetera, to get at our other goals, recognizing that if our aid program continues as it is now, it's not a vehicle for these other things. And Congress and the public has to be educated on that as well. And I think that when we talk about development and diplomacy as twin pillars, we have to think carefully about what that really means in terms of soft power, in terms of other objectives, as well as the good things that this brings. So I think all of those issues need to be faced. I think the more candid we are about them, the less backlash we're going to get and the more support we can build for a more sustainable program.
Todd.
Thanks. I'd like to end where I started, which is to say that I don't think that there's a moral alternative to providing full access to people with treatment. Lowering the bar and lowering our expectations as a way to succeed is not really a path to success for the people whose lives are going to depend on this. So I think we just have to figure this out. And I recognize, and I think you've done a great job of raising some of the major challenges ahead. But even though I'm the negative, I'm going to be positive. I think that we really need to be affirmative and aggressive in our effort to increase the pool of resources available, not only for HIV and AIDS, but also for the broader range of health and development issues that need support. I'd like to offer, if you will, 3 steps, I think, that are a way forward on this. They're not going to solve the problem, but I think they get us some of the way there. One, which certainly came out in Vienna, is the need for efficiency. It's very clear that we are not getting the value that we should be getting from the resources. In prevention, there's a lot of evidence there that programs are often mistargeted and ill-advised. And in treatment, there's a lot that we could do to lower the costs of treatment to provide clinically effective treatment with reduced drug prices and with reduced cost of attendant care. I think that if we're able to achieve a 30% savings in treatment, that's 30% more people that can be treated with the money that we have available. Second, I think we need to be expecting more from implementing countries. While they do already provide a substantial amount of the resources in totality that are provided to HIV, it's not enough. Steve, you mentioned earlier the walk away of the Abuja targets. That simply is unacceptable. Countries, governments, are the ones that have the primary obligation to address the health needs of their citizens. It is not the United States government's primary responsibility. It is the governments of those people, and we should be pushing harder to have them accept that responsibility and put more on the table, including resources and including political leadership. That also means that we need to look at some of the countries that have been beneficiaries of resources and may now no longer need those to the same extent. Countries like China and India that have done well with resources from the Global Fund and others may now need to look differently at their approach to those institutions and perhaps become donors rather than grantees. Third, I think that we have to do more to get money from existing donors. I think Lori Garrett from the Council on Foreign Relations has done an excellent job of pointing out that the U.S. has to do more, but certainly a lot of the other governments have done a lot to step back from commitments. Italy is the only government I know that's completely reneged on a commitment to the Global Fund. They have not paid their 2009 pledge. I don't think they've even made a 2010 pledge. That's shameful. And what's also shameful is that the other GA countries aren't holding Italy accountable for walking backwards on a commitment that they made. I think that we also have to look to find alternative sources of funding, recognizing that innovative financing is a complement to, not a replacement for, straight-up aid. But debt to health, the Unitaid, the Millennium Foundation's Massive Good, those are all opportunities that should be exploited, and there are probably more. We could probably do a lot more to harness the skills of the private sector. And of course, the fourth one is you need to join the One campaign by going to one.org.
Okay. Steve, last word to you.
On the foreign policy piece, there's no getting around the reality that the Horn of Africa is a really tough place, and we're going to have to continue to work it. And we've got governments that are rather ossified and have low legitimacy and are highly autocratic. I also think it's important to sort of end on a more positive note. This was a good week with respect to the Kenyan constitutional referendum.
Not to mention the U.S. Constitution.
And this was an outcome. This was an outcome in the Kenyan. This is a place where we're making massive health investments and massive humanitarian and other developmental investments. But we also made the political commitment. Yeah. We had the Secretary of State. We had the Vice President in Nairobi. We had Johnny Carson and Michelle Gavin repeatedly engaging. This became a top priority at the top echelon of our government. And I think you can make the case that when that level of investment is made over a sustained basis of 18 months, that you can move the dial to the degree we can to get the kind of outcome we saw this week, which was a very positive outcome and for Kenyans, a terribly profound outcome. And we should keep that in mind. I mean, we do get results in cases where we could argue we have limited leverage innately, but when we carry the leadership to that level, we can see some outcomes.
All right, just to bring this wonderful discussion to a close, I think we can observe that looking back, the U.S. commitment made in 2003 to create the PEPFAR program was amazingly important, and I think no one here would regret that the U.S. made that very important commitment. Similarly, the commitment of the G8 in 2005 to universal access was, in many respects, a tremendously important and noble commitment. It was also fair to say that no one fully understood the implications of those commitments when they were made in either 2003 or 2008. And we also did not foresee the future. We did not foresee a global economic downturn, the straitened resources that many countries now face. That said, these programs have unequivocally produced a phenomenal success. There are millions of people alive today who would not be alive otherwise. And to move to sort of is the glass half empty or the glass half full, we've heard some different perspectives on that score. We've heard that the glass is half empty with respect to foreign policy. We've created perhaps an entitlement culture around the rest of the world, with much of the rest of the world expecting on U.S. continuing to step up the plate to meet most of these obligations. We've heard that potentially we've created the seeds of a backlash if the U.S. ever backs down from these commitments or fails to rise to meet increasing commitments as fast as expectations are, that there will be this backlash. On the side of the glass being half full, we've heard the perspective that, first of all, there's no moral alternative anyway to this. What is the alternative that exists to walk away from all these people? We've heard that, in fact, to a large degree, PEPFAR in particular has been a diplomatic success for the United States and cemented more support for U.S. foreign policy than might have been the case otherwise. We've also heard that there is potentially a lot to be gained now from employing the recent science, the advances in the science, to making even further inroads into the HIV/AIDS epidemic, and that it is time, in fact, to make a new commitment on that score. And we've also heard from Todd's perspective that the world has plenty of money, notwithstanding the fact that the resources seem straitened, and that the case should continue to be made to attacking the HIV/AIDS issues in the context of continuing to address more global health issues broadly. So I think what we're left with is one area of agreement between these two, which is that we should certainly begin to move more of our assistance to the multilateral perspective, that would be a positive going forward. And also that we should obviously make a commitment to making the resources that we do expend on HIV/AIDS to have them used as efficiently as possible, to make to bring down the cost of drugs, to make the distribution as efficient as it could possibly be, to get the maximum bang for the buck. Because when we put it all together, perhaps there is indeed a case to be made that there is an end game with HIV/AIDS. And if we can just get through this period and employ the new scientific discoveries and do it all as efficiently as possible, we really could ultimately turn the epidemic around. I don't know that I'm empowered as the moderator to declare a winner of today's debate. I would say, from my perspective, the winner has been rational discourse. So join me in thanking all of these three for a terrific discussion.
Thank you, Susan.
Thanks very much.
Thank you, sir.